Good afternoon, everyone. This is my PhD topic, the role of inflammation in the progression of abnormal glucose tolerance. My name is Huang. Here is my team. My vision is global access to education and resources to prevent prediabetes from progressing to type 2 diabetes. My mission is to determine which factors affect the progression of prediabetes into diabetes. Here are two specific goals. Both two projects are systematic review and meta-analysis. For the first project, we are investigating the effects of inflammatory mediators on the development of diabetes in adults with prediabetes. Nowadays, prediabetes is rising globally, with 5 to 10% progressing to diabetes annually. Over 470 million people will have prediabetes by 2030. The reason for prediabetes progression is very complex. Obesity, dyslipidemia, hypertension, gender, smoking, and inflammation are key risk factors. Especially inflammation fuels these risk factors and is central to the development of prediabetes. According to the literature review, the chronic low-grade inflammation, such as elevated IL-6, TNF-alpha, and CRP, drives insulin resistance, disrupts glucose homeostasis, and increase the risk of type 2 diabetes. However, most reviews focus on non-diabetic populations rather than on prediabetes and its progression to type 2 diabetes. So our aim is to explore how inflammatory mediators influence the progression from prediabetes to type 2 diabetes. The clinical question is, do inflammatory mediators modify the risk of developing diabetes in prediabetic adults? The population is adults with prediabetes. The exposure or comparator is levels of inflammatory markers. The outcome is development of diabetes. Our hypothesis is elevated levels of inflammatory markers are associated with an increased risk of developing diabetes in adults with prediabetes. The clinical implication is CRP levels may help identify high-risk prediabetic individuals for early intervention. Here is the final search key. We divided them into 3 domains. The domain 1 is about prediabetes. The domain 2 is about inflammatory markers. And the domain 3 is about progression or regression. After main selection and citation tracer, about 55 articles remained. About the results, in the figure 1, we could observe that individuals with higher CRP levels over 1 milligram per liter had about 2.5 times the risk of progressing from prediabetes to diabetes compared to those lower CRP levels. And the heterogeneity was low between studies. Although the confidence interval was wide, there is still a tendency of increased risk of diabetes in prediabetic with CRP levels greater than 1. In the figure 2, it is about proportion of prediabetes progression to diabetes. And across 13 prospective cohort studies, about 19% of individuals with prediabetes progress to diabetes. And we use the random effect model due to high heterogeneity. Although the wide prediction interval reflects large variability between studies, studies with higher progression rates also tended to report higher baseline CRP levels. And next, we will do the meta regression to further explore high heterogeneity. So this is my first progress report. For the second project, we are investigating the effects of inflammatory mediators levels on disease progression and comorbidities in patients with metabolic-associated steatotic liver disease. Why we need to care so much about MASLD? It affects approximately 30% of adults, especially those with obesity, 80%, and type 2 diabetes. The incidence of MASLD has increased by nearly 60% from 1994 to 2014, reaching about 5% in 2019. According to the literature review, the chronic low-grade inflammation is a key driver of MASLD, closely linked to obesity, insulin resistance, and metabolic disorders. So, HS-CRP is a potential biomarker for assessing MASLD severity. Our aim is to investigate how inflammatory mediators and obesity influence disease progression and comorbidities. The clinical question is do the level inflammatory mediators correlates with the disease progression and comorbidities in MASLD. The population is MASLD or MASLD. The exposure is obesity. The comparator is non-obesity. The modification is inflammatory mediators. The outcome is progression to comorbidities. Our hypothesis is inflammatory mediators may contribute to the MASLD progression and the comorbidities. The clinical implication is targeting obesity-related inflammation in MASLD may help slow disease progression and reduce comorbidities. This is my preliminary research key. It also divided into 3 domains. The domain 1 is about MASLD. The domain 2 is about inflammatory mediators. And domain 3 is about progression on comorbidities. This is the key articles. In summary, these 2 projects are investigating the effects of inflammatory mediators in the metabolic disease. Maybe in the future, we could find the interplay between these 2 diseases. Finally, I will end up with Pablo Picasso's words, inspiration exists, but it has to find you working. Thank you for your attention.
Thank you very much. Do you have someone a question? Okay, I have several questions. What is a low-grade inflammation? How can I prevent it?
What is my...
So what drives low-grade inflammation, as you said?
What drives the low-grade inflammation?
Yes.
Yes, I didn't know very clearly the mechanism now, but I just want to say that insulin resistance maybe. I think maybe, and now I'm also very interested in microbiome. Maybe, I don't know, or maybe obesity. So I didn't know now.
Okay. The other one is you said there are several inflammation factors that contribute to the low-grade inflammation, but only showed CRP in your results. Are there any information about the different inflammation markers, or only CRP was eligible for statistical analysis?
Okay, we didn't finish the analysis, and we have some results, and the IL-6 and TNF-alpha, yes. And
Okay.
these two results we still analyze.
Thank you.
Okay, more question from the floor. Can I ask something that you mentioned that maybe IGT patients have higher risk for to progression to diabetes, and maybe there could be need of interventions. What do you mean by that? Which interventions must be conducted in a patient, in an IGT patient with high inflammatory levels?
IGT.
Because as I understood, in a IGT patient with higher CRP level, there will be a higher risk of progression to diabetes. So which interventions would you recommend for such patients? For example, will you measure the hemoglobin A1C level more regularly, or would you recommend OGTT testing more regularly for such kind of patients? So there will be, anyway, there will be very marked consequences of your results. So I have one more question regarding your second topic. How will you examine the progression of a steatotic liver? What is the method of the measurement of the progression of a fatty liver in the studies? Because inflammation will affect the progression of fatty liver, if I understood well. And what is the method? Ultrasound, for example, or liver enzymes activities will be measured? Hopefully. Okay.
Okay. Thank you for your question. And for the second project, and I didn't now I just investigate very not very deeply. So you can ask me the first project because the second project is not just the idea, and I didn't. Yes.
But your idea to examine the progression of a fatty liver in a patient with higher inflammatory status. Okay, never mind. And microbiome is everywhere, so you have right in general. Okay, and it can affect many diseases. Thank you for your presentation. Okay.
Thank you.